tends to be geared towards keeping the hemoglobin normal. So it will steal iron or direct iron more towards making red blood cells and hemoglobin. And that means we're losing iron for other purposes, for muscle, etc. Right? Now, this is a situation where we say you are iron deficient, but you don't have anemia. And this is important because this is a stage where you will start feeling symptoms associated with iron deficiency, which we'll talk about shortly. But then if all we did at this stage was get a complete blood count, you go see your primary care doctor and say, I'm feeling worn out. They check a complete blood count and your hemoglobin may be normal, and you may be told, your blood counts are fine, don't worry about it. But there is a problem. And it's only after all of this, when even that state is exhausted, that we develop anemia because we've completely emptied all of the sources of iron. And that's when you start to develop anemia. And all of this typically tends to happen gradually over time, unless we're having a massive bleed or like a 4 or 5 hour nosebleed or GI bleeding that's pretty acute. Okay. Having spoken about anemia and iron deficiency, let's talk about some of the symptoms of this. What will somebody experience? You can split this into the response of the body to a decrease in blood supply, right? So there's not enough blood floating around in the pipes because we have had a lot of bleeding. Then the heartbeat goes up to try and maintain circulation so you can get fast heartbeat. And there's also the response to blood loss, what we call hypovolemia. So the blood pressure will drop in addition to the heartbeat going up. And we go into what we call shock because blood is not flowing to places it needs to flow to. And typically this will result in people losing consciousness, fainting. And both of these tend to happen when we have very quick loss of a lot of blood. But when this happens more gradually, then we start developing symptoms that are associated more with not having enough oxygen, weakness, fatigue, headaches, shortness of breath with daily activities or minimal exertion, not able to exercise is another one. So these are some of the general manifestations of anemia. Could happen to anybody regardless of the reason of the anemia. Now, there are some things that are specific to iron deficiency. People can develop brittle nails. Certain cravings, typically for ice, can be for starch, can be for clay, called pica. Restless legs is a common cause or common manifestation of iron deficiency. A decreased ability to concentrate, particularly in children. Grades may drop in school. Poor memory, fatigue, muscle aches. Remember, there's iron in myoglobin. And also certain findings that are classic for iron deficiency, spooning of the nails, changes in the tongue that you can notice, as well as changes around the corners of the mouth, which are all classic for iron deficiency. So how do we diagnose iron deficiency then? Clinical suspicion is key. And then we do blood tests, a complete blood count, which will tell us the red blood cell count, the hemoglobin, and a few other clues in that complete blood count that will point us towards low iron levels. A blood smear, as hematologists, we tend to look at these all the time, and there are classic findings on a blood smear, and an iron panel or ferritin. Remember that a ferritin that is below 15 is absolutely iron deficiency. There is no other reason, explanation for it. And the other point is also more important here, which is a normal ferritin does not rule out iron deficiency, because there are situations where a ferritin can be elevated even when a person is low on iron. Lastly, how do we treat iron deficiency anemia? We tend to say first-line treatment is oral in general, and that you can replace either as heme iron or non-heme iron. There are a bunch of preparations available for plant-based iron. There's only a couple for heme-based sources. And the more iron you take in and put in your stomach, the more toxicity you may feel, constipation, nausea, bloating, things like that. And in general, the heme preparations seem to be better tolerated because they have lower iron content in them. Now, this is important to remember. Yes, a healthy diet rich in iron-containing foods is important, but we're not going to eat our way out of this if it is severe iron deficiency, right? Eating red meats, liver, oysters, spinach 3 times a day is unlikely to make a big difference because there is a limit to how much iron we can absorb from our intestines at any given time. You can eat a gram of iron a day, but like I said, we absorb only 1 to 2, maybe 5 to 10 milligrams. So if you eat a gram of iron a day, 990 milligrams of that is going to come right out and not be absorbed, right? So what about intravenous iron? This should be considered in people who are not tolerating oral iron, have ongoing blood loss for which we cannot catch up just by taking oral iron. So while I said in the previous slide, oral iron is what we would prefer to do up front, that also depends on how much somebody is bleeding. Because if we know we'll never catch up with oral iron, we'll skip that and go straight to IV iron too. So there is a place for going straight to intravenous iron, which has a lot of advantages. Large amounts of iron can be given to you at one time. It's reliable, it's not impacted by absorption, and it overcomes whatever toxicity from the intestines that people feel. There are some disadvantages, primarily time, cost. Risk for reactions comes up periodically, particularly by physicians who are not used to using intravenous iron replacement. But I want to reassure you that this is rare, and this intravenous iron is typically very well tolerated. Here is just a table for completion's sake of all of the preparations available. Monoferric here, the last but one on this list, is a new kid on the block, just became available in the United States. And you can see each of these have different amount of iron we can give at a time, and the amount of time it takes to give them is different as well. I won't go too much into this in the interest of time. Now, here are my last two slides. So those of you that were sleeping, it's time to wake up. Let's talk about iron deficiency anemia specific to HHT. 50% of people with HHT have anemia. And iron deficiency, even without anemia, can be symptomatic and cause these symptoms: fatigue, muscle aches, restless legs, hair loss, decreased attention span. We talk about it in children, but I think it's a problem in adults too. Bear in mind, iron deficiency is frequently missed in HHT patients. And that treatment of iron deficiency, even in the absence of anemia, is an important component of the care of a person with HHT. Here are my take-home points. Sorry, this is my timer to say my 15 minutes are up. My last slide, my take-home points. So anemia due to iron deficiency is common. Iron deficiency without anemia can be symptomatic. All HHT patients should be screened for iron deficiency and anemia regularly. Dr. Al-Samkari is going to talk more about that. Aggressive correction of iron deficiency improves a person's quality of life. And all of you should be familiar with the guidelines that Dr. Al-Samkari will talk about. And I encourage you to share them with your medical providers because it will help in your care. We will get to questions after the presentations. I'll hand this back to you, Dr. Al-Samkari.
Great. So while we're switching over to the next presentation, let's do another poll. So if you can, just take a few seconds to answer. I get iron studies measured every time my doctors get blood tests. Yes, no, or not sure.
All right. So first of all, just want to thank Cure HHT for putting on this very important webinar and webinar series. And of course, Dr. Kasthuri for starting us off with a spectacular introduction to anemia, iron deficiency in HHT. And I'm happy to pick up where he left off on discussing the guidelines. First, let's talk about this poll. So about 2/3 yes, get iron studies measured every time their doctors get blood tests. 20% no, and about 12% not sure. So, you know, in HHT, it's not a prerequisite that every single time you get your blood drawn, you have iron studies checked, but it's something that really should be done routinely. And at different intervals depending on the person and the degree of bleeding and the history of anemia or lack thereof. And we will talk about some of those things. It really dovetails very nicely into the discussion of the guidelines. So thanks to Nicole, actually first, these are my disclosures. non-relevant for this talk. And thanks to Nicole for her wonderful introduction of the guidelines just generally. I don't have to spend too much time here, but this was really a really monumental undertaking, just hundreds and hundreds and hundreds of hours of time and effort from over 60 individuals, really from all walks of life, patients with HHT, providers, from all the various specialties in medicine. Generous gift that allowed it to be possible. And of course, our chairs, Doctors Fawn and Major and Hetz, who were absolutely, spectacular leaders in this. Here's our group, Dr. Kasthuri and myself that you can see in this photograph. And there are 6 other members of the Anemia and Anticoagulation group that definitely deserve recognition as well. All right, so I won't get into the weeds, only to say that there are ways to develop guidelines in a very scholarly and in-depth way, and we followed one of those methodologies to do this over a long period of time. So you may wonder when I present these things, why they're worded the way they are, or for example, why certain things are mentioned and other things may not be mentioned. And it's all very deliberate. Every single word in the recommendation was selected for a reason. And we were limited in the number of specific recommendations we could make, so as to not let it get out of control with one category. So we picked what we thought were the most important. So the first anemia recommendation was the expert panel recommends that the following HHT patients be tested for iron deficiency and anemia. All adults, regardless of symptoms, and that's a major take-home point, and all children with recurrent bleeding and or symptoms of anemia. So one of the things we recognize in HHT that's been very clear to us for a long time is that the bleeding gets worse with age in most patients. And many children, while they have bleeding, they rarely have anemia, or they're much less likely to have anemia as compared with adults. They certainly can and do develop it. But it's just so common in adults that the screening piece really, really important for adults to be screened regularly, okay? And what does that mean, all right? So screening, in this case, we're talking about a CBC and a ferritin and iron and total iron binding capacity or transferrin saturation. So the numbers that we look at are to evaluate somebody's iron status are their ferritin, which is a representation of the storage iron in the body, and the transferrin saturation, which is kind of a more of a representation of how much iron is really kind of floating around in the blood at that given moment. And so the transferrin saturation is a calculated number from the serum iron and the total iron binding capacity. For those of you who take a look at the labs that your doctors are ordering, you may wonder, what are these numbers? What do they mean? And that's what it is. It's the ferritin is the storage iron, and the transferrin saturation is a more immediate representation of how much iron is in the blood. Bleeding and risk for and severity of anemia in HHT is a moving target. So people will have different intervals for screening. Some people, as we saw from that very first question, get screened every month. Some it's every 3 months, some it's every 6 months, some it's yearly. I generally don't screen any of my HHT patients less commonly than at least once yearly, just given how common bleeding and anemia is in this disease. So the screening interval really should mirror your specific bleeding symptoms as well as your anemia history. For people who are getting regular iron infusion, obviously you're going to be followed with these tests routinely. For those who are on oral iron, don't require iron infusion, or who get intermittent iron infusions, then the interval will be less frequent. But it will be important to not let up just because you are tested one time or twice and you weren't anemic or you weren't iron deficient. It can develop over time. The second anemia recommendation, the expert panel recommends iron replacement for treatment of iron deficiency and anemia as follows. initial treatment with oral iron, intravenous iron replacement for patients in whom oral is not effective, not absorbed, or not tolerated, or for those who present with quote unquote severe anemia. Okay, so what does this mean? Let's talk a little bit more about this. This is, I think, the most the recommendation that is worthy of the most discussion. So first, we'll talk about oral iron. So it's fair to say that most, if not all, but most patients will try oral iron or be started on oral iron when they develop iron deficiency and or anemia. So, some docs get a bit overzealous when prescribing iron. They'll prescribe it 3 times daily from the start. That can be very challenging to tolerate in terms of gastrointestinal symptoms, constipation, nausea, bloating. So, in the guidelines, it's really recommended that it start with 1 pill once daily. All right, and there's lots of different formulations. Generally speaking, the formulation has a total milligrams and then a milligrams of elemental iron. And the amount of elemental iron we're looking for in these pills is between 35 and 65 milligrams. So if you look at a typical like ferrous sulfate you buy from a pharmacy over the counter, that'll be 325 or 324 milligrams, but the elemental iron part will be 65 milligrams. So that's what we mean when we talk about the elemental iron piece. If this is inadequate to resolve the iron deficiency and you tolerate 1 pill once a day very well, then you can try twice daily dosing and see if that's enough to carry you through. It's important to take oral iron in between meals if at all possible. It absorbs better on an empty stomach, unlike most things, most medications, which are often taken with food. It also absorbs better in an acidic environment. So a trick of the trade that we suggest is taking it with a little vitamin C or a little orange juice, something acidic, just, in sips or a cup, not a full stomach full of food. And I generally prescribe a stool softener at the same time that I prescribe iron for many of my patients. It's just, there's lots of over-the-counter stool softeners, but just to make sure that if you run into an issue, that you don't have to kind of suffer for a while until you can talk to your doctor about what to do about it. Just constipation is just quite common. So if oral iron is not tolerated, the initial formulation you can try another formulation. I put success unlikely. Maybe that's a bit too pessimistic, but it's just very common. I've found, at least in my practice, when somebody doesn't tolerate one oral iron formulation, it's unlikely they're going to necessarily tolerate another one that much better. They do sometimes, so it's worth trying. And we really expect at least a 1 gram rise in the hemoglobin value on the complete blood count in 4 to 6 weeks. And if we're not seeing that, then this is not working, and the bleeding is too much, and an oral iron alone will not do the job, or there's another contributing cause of anemia. If the oral iron doesn't normalize the hemoglobin and the iron stores, okay, and really what's normal in terms of iron stores? Well, there isn't a specific threshold for either ferritin or the transferrin saturation. There isn't one special number, and somebody can have a certain ferritin value and not be iron deficient. Another person can have that same value and be iron deficient. But generally speaking, if your ferritin is above 50 and your transferrin saturation is above 20%, you're unlikely to be iron deficient. And so those, I think, are reasonable thresholds to consider. Dr. Kasthuri pointed out in his talk, less than 15 ferritin, yeah, that's definitely iron deficiency. It's really unlikely that is not representative of significant iron deficiency. But there's kind of a gray area, a gray zone. And if you're above 50 and at the ferritin, you're probably in good shape. Above 20% with a transferrin saturation, you're probably in good shape. If you don't get there with oral iron, then IV iron is likely necessary, all right? I think that it's important, and the guidelines, also make this point, that there should be a relatively low threshold for IV iron in HHT. If the degree of iron losses aren't adequately replaced by diet with oral iron, then you may need intermittent or ongoing IV iron. All right, and so that's an important piece. And a lot of the times, docs and sometimes patients are a little bit nervous about pulling that trigger, going to an intravenous infusion. Can't we optimize the diet more? Can't we optimize the oral iron more? Chances are, if you haven't gotten it down within the first 3 months, that you're going to need to go to that IV iron. The way that the IV iron dose should be given, oftentimes people will think, okay, well, I'll get an infusion that'll get me to where I need to be. Your doc really needs to be cognizant that not only are you deplete of iron certainly if you're anemic, deplete of iron in your red blood cells and the total amount of red blood cells you have, but you're also total body iron depleted. And so it's really important to make sure that you're adequately repleted. And if you still have ongoing bleeding, which most HHT patients do, then that's going to have to be monitored and probably repleted again and again and again, and so on and so forth. So what's often done, there are formulas to figure out how much total body iron deplete a person is, or one can administer about 1 gram or 1,000 milligrams of IV iron and recheck after a few weeks. Once on IV iron, really people should be monitored. I recheck my patients every 1 to 3 months to determine the infusion interval, see how long they can go in between infusions. And I don't hesitate to repeat an infusion when their ferritin is less than 50 to 70, when the transferrin saturation is less than 20 to 25. I don't want to get behind. I don't want somebody to develop iron deficiency and we're constantly playing catch up. The person, has restless legs at night, they're fatigued, they're not performing as well with cognitive tasks at work or at school. There's no reason to live like that. So, IV iron is a low risk intervention, and it's important to have normal levels of iron. All right, we could do a whole talk on what IV formulation is best or what is preferred or what have you. There isn't data comparing the different formulations, certainly not in HHT. But, you don't want to spend your life in the infusion suite, right? So there are certain formulations that give much more iron than others. So one iron infusion is not the same as another iron infusion necessarily. It can have another, infusion A can have 3 times the iron as infusion B. And people typically like to get as much as they can in one infusion. So there are certain products that are better at that. And you can talk to your doctor about that. There is one product called ferric carboxymaltose or Ejectifer, which I don't recommend for regular iron infusion in HHT patients because it can cause the bones to be brittle due to reduced phosphate over time, and that can lead to fractures. But other iron formulations don't do that. So it's okay to get repeat infusions of other formulations. There's one called ferrimoxitol or Ferriheme that makes it so that you can't get an MRI within 3 months because it can't be reliably read. It interferes with the MRI reading. All right, so that was the longest recommendation. The next one is that the expert panel recommends red cell transfusions in the setting of hemodynamic instability or shock. So someone who's having a very, very brisk, dangerous, life-threatening bleed. People with certain medical conditions that require a higher hemoglobin target. For most HHT patients, a normal hemoglobin should be the hemoglobin target, but for some who have severe bleeding, we can accept a lower target. Need to increase the hemoglobin acutely, such as prior to surgery or during pregnancy. An inability to maintain an adequate hemoglobin despite frequent iron infusions. And that's the most common circumstance that HHT patients will receive red blood cell transfusion. So, in general, if someone is getting iron, say, every 2 weeks and their hemoglobin is not an acceptable place, the doc may add on a red blood cell transfusion to try and keep it at that acceptable hemoglobin. If somebody is getting to this point, then there should be a discussion about disease-modifying therapy, therapies to stop the bleeding or slow down the bleeding. There's a way to measure this. I won't spend much time on it, except just to say that, following the amount of red blood cell transfusions and amount of iron infused into your body over time is something that your doctor should be doing in one way or another. This score I have on this slide is one way to do it, but they should be following it and monitoring it in response to therapies. All right, the last anemia recommendation, the expert panel recommends considering evaluation for additional causes of anemia in the setting of an inadequate response to iron replacement. All right, so this is pretty self-explanatory to the docs, but just, I empower you just to remind your doc if, you're getting lots and lots of iron and your blood counts aren't normalizing, your iron levels are normal, your blood counts aren't normalizing, then there needs to be a discussion. Is there something else going on? There are other blood tests that can be checked, other evaluations that can be done. Maybe you need to be referred to a hematologist if you're not already seeing one. That's just an important aspect. Now, this area of the guidelines was technically anemia and anticoagulations. And that was how Nicole introduced it. We're spending our time talking about anemia, but I don't believe there's going to be a separate discussion of anticoagulation. So I include these just here very briefly. These anticoagulations, use of a blood thinner. And the main thrust of this is that, and despite the fact that HHT is a bleeding disorder, if you need a blood thinner or a medicine to reduce the functioning of platelets called an antiplatelet agent, if you need a blood thinner, and that's indicated by another one of your medical conditions, your doctor should probably give it to you, right? Unless there isn't a very, very, very strict reason not to. People get scared about doing this in patients with HHT because they're worried about making the nosebleeds worse or making the GI bleeding worse. The reality is that patients with HHT aren't protected against blood clots. In fact, they may have a higher risk of blood clots than the general population, even though they have a bleeding disorder. And so it's really, really important that this is not missed and not overlooked. All right, that's the first anemia, or excuse me, the first anticoagulation recommendation. And the second is, if you do require a blood thinner, oftentimes docs like to give more than one for certain diagnoses. If they can get away with one, they should stick to one. Only when they really, really, truly need to add a second one should a second one be added, because the bleeding intensity can really go up when a second blood thinner is added. So in summary, iron deficiency is very common in adults with HHT. Routine screening is required. Bleeding and therefore severity of anemia in HHT is a moving target. So that interval of being evaluated may change over time if your bleeding gets better or worse. Patients with mild bleeding and iron deficiency and/or anemia can trial oral iron, but may need intermittent iron infusions. And those with more severe bleeding will likely require regular iron infusions to treat the anemia and prevent iron deficiency anemia. Red cell transfusion is really indicated for very severe bleeds, as well as those individuals who are not meeting their goals with iron alone. And docs really should not hesitate to give IV iron in the chronically bleeding HHT patient. Pull that trigger. Don't be scared to pull that trigger, or ask your doctor to pull that trigger if it's indicated. And there really is no reason, I put this in bold because I think it's really, really important. There's really no reason for HHT patients, the vast majority of HHT patients, to live with chronic anemia. So regular aggressive iron repletion is the standard of care, and disease-modifying therapies to reduce bleeding should be considered when the hematologic support requirements, the intravenous iron and or red blood cell transfusion, become significant and burdensome.
Great, thank you so much. So as we move on to Kim just sharing a bit of her journey, let's do our last poll. And this will just take a couple of seconds, but my doctors give me iron infusions even if my hemoglobin level is normal to prevent anemia from occurring.
So I think that, I mean, look at these results, 70% no, 20% yes, and 10% not sure. I mean, these results I mean, it's the reality is that not every person, on this call needs to run to their doctor and demand an iron infusion, but, there's a lot of people sort of playing catch up when this happens, if you wait until the hemoglobin to come down, if you remember Dr. Kasthuri's slide that showed what happens when the iron levels go down, you're already way behind the 8 ball. Iron stores in your body are already gone. So I will monitor the iron stores, the ferritin and the transferrin saturation of my patients regularly, and will not hesitate to give them IV iron long before their blood counts have dropped. If their blood counts have dropped, I'm already behind where I should be. So, I think that this question illustrates very nicely how much of an issue this is, I think, in the care of HHT patients.
Great, thank you so much. So if you want to stop sharing your screen, and that's fine. And then Kim, if you want to go ahead and give us an introduction to your anemia journey.
Well, I'm a 50-year-old female, almost 51. I have a family history of HHT, my grandmother, my mom, my aunts. So I grew up with a lot of bleeding in the family, a lot of testing going on, a lot of blood transfusions and all that. I started significantly bleeding in my teen years, and it got progressively worse after each child I had 3 kids. During my pregnancy of my 3rd child is when I started getting the iron infusions, because my ferritin was so low and I was bleeding really bad. I was 33. Ever since then, I've been getting them on a regular basis. I find that if my ferritin falls below 100, I feel it physically. I start getting more tired. I can't sleep as well. I have some insomnia. I crave water a lot, like lots of cold water. And when I get really bad anemia, I get where I'm cranky, headaches, my hair starts falling out a little bit, brittle nails, my legs hurt, I have heart palpitations, I have trouble breathing. Like if I go up a flight of stairs, you would have thought I ran 5 miles. I've had several blood transfusions along the way. I don't even know how many, there's too many to count. And what I find works the best for me is the IV iron. I've had the dextran, the long dose, many times, and I've started to do the shorter doses, which seem to do a little better with me as I get older for some reason. I think because I get them closer together and we maintain it more, where the other one just falls out real quickly. I also find that once my iron levels, my ferritin levels start dropping, I start bleeding a lot more. That's like a pretty good indication long before I get to the 50 or whatever, because what happens for me is once my ferritin levels start going down, I'll be fine. Like I'll get blood work done, my hemoglobin will be 10 or something, and my ferritin level will be like 100. Then all of a sudden, 2 weeks later, my hemoglobin's down to 8 and my ferritin's at 15. Like it plummets really quickly once it starts going down and the bleeding starts. I find that I'm trying to look at my notes here, that just maintaining the iron makes my life so much better. Like I have energy, I can do things with my kids, I can, participate in outdoor activity, not just outdoor, just outside activities where, when you get tired, when my anemia is low, I don't even feel like getting dressed or doing my hair, or like, I don't know, it's a game changer staying on top of the iron. I get my blood work done pretty much, I listen to my body, but definitely at least usually once a month, every now and then every couple months, sometimes every couple weeks. It's really important as an HHT patient, I think, to stay on top of things. And, this has taken me years to do. I was in my mid-30s before I started taking it seriously. So that's one thing I would say as a patient, that you really should stay on top of it, ask questions, and you're in a partnership with your doctor. Get a doctor that listens to you and every HHT doctor I've had a couple now, have been so open and so, it's a true partnership in my healthcare. And I like that. I've had doctors, you know, the ER doctors, you go to it. I don't advise going to the ER without talking to your HHT doctor because they don't really know much about HHT and they don't listen to you. They'll be like, oh yeah, I heard of HHT while I was in medical school, and you know more than they do at that point. So just be cautious, because I've had doctors do crazy things with my nose in the ER and things like that. And just stay on top of your anemia. If you stay on top of your anemia, you'll feel better and you'll have less blood problems, I find, for myself personally.
Great. Well, thank you so much, Kim, for sharing that. I know that's not always easy to do, to put yourself out there. And I really appreciate Drs. Kasthuri and Al-Samkari for just such a thorough overview of anemia and the guidelines. And we do have a lot of questions. So if everybody's willing to hang on an extra 10 minutes or so past, we will go a little bit over our 1 hour just to try and answer as many questions as possible. So Dr. Al-Samkari, this one is geared towards you. It asks, why do HHT patients have a higher risk of blood clots in general? And is this peculiar to HHT or peculiar to patients' comorbidities?
Sorry, Nicole, your audio cut out mid question. Can you repeat it?
Oh, I'm sorry. Why do HHT patients have a higher risk of blood clots?
Yeah, so that's a great question. It's a question we don't know the answer to, but it's something that we have observed in certain observational studies where we watch HHT patients over time. And so one of the things that we have recognized, actually just generally, is that patients who have chronic iron deficiency may have an increased risk of blood clots, and HHT patients are very, very commonly iron deficient. And that piece, you know, you may ask, well, why is that? Why is it more likely that you have blood clotting if you're iron deficient? It's not entirely worked out. There's more and more research being done on it. But one interesting thing, sort of think about it from an evolutionary perspective. The thing that caused, you know, if you were running from the saber-toothed, the primitive human was running from the saber-toothed tiger, and they were bleeding, right? That was the cause of iron deficiency, was bleeding, right? And so the body tries to stop bleeding by increasing blood clotting factors. And so if you're iron deficient now in 2021, the body still maybe increases its clotting propensity to try to stop that bleeding. So, but we don't really understand it, but it's something that we've observed.
Okay, great. Thank you very much. So we have a question, maybe Dr. Kasthuri, what ferritin level is low enough to get iron infusion?
Yeah, great question. My cutoff is 50. I don't like my HHT patients going below a ferritin of 50. Now, again, this is a bit nuanced in that if it's a person who's also got some comorbidity or another medical problem that it has an inflammatory component to it that drives up the ferritin, then it may be 100 instead of 50, right? So 50 is a hard stop for me, but there are some patients in whom it's higher. Like Kim mentioned, you know, it's 50 may be too low for Kim. You know, we've got to keep it at a higher number, but that's definitely a hard stop. And the reason this becomes important is ferritin is one of those blood tests that has a giant normal range. Depending on the test, the normal range goes from 3 to 150 or 200. So unless the ferritin comes back 0, the physician may take the stand of you're not iron deficient, which is ridiculous, right? So that's something to be aware of. It's normal ranges, but yeah, 50.
Okay, and then kind of tagging on to this question came in ahead of time, was asking, why is the ferritin count more important than some of those other iron numbers?
Yeah, that's a great question. And the ferritin is the best reflection of the body's iron stores, right? The other numbers matter too, but they change day to day because some of them reflect how much iron or how well iron is being absorbed from your intestine and how well it's being transported in your blood to get to the storage compartment. So they are probably more susceptible to, hey, did I do the testing after you took your morning iron pill? And those numbers can fluctuate a lot greater than the ferritin, which is more of a reflection of how your body's iron stores do. Which is why if your body's iron stores are being depleted and your ferritin starts to drop, it's a time when we should start putting iron back in, because we know where that's going to end.
Okay. I have Glenn, who's on with us today, is asking, what volume of blood loss from the nose is dangerous?
Yeah, so that's a great question. You know, if we're talking about what volume of blood loss from the nose can lead to a significant drop in iron stores, for example, it can be really difficult to measure just exactly how much blood one is losing, even with a severe nosebleed. I think if someone is having, and your doctor, you know, has various ways to rate how severe your nosebleeds are over a period of time. I have patients that they'll get one horrible torrential nosebleed and their hemoglobin drops 2 or 3 grams. You know, that absolutely happens. Most of the time, it's really one nosebleed is not necessarily making a huge dent, but it's just the fact that there's multiple nosebleeds over the course of a day, and then, you know, 7 days in a week and 4 weeks in a month. Over the course of 1 or 2 months, that causes the you know, iron stores to come down and the hemoglobin to come down. One other thing I'll add, just to make I think an important point, is that a lot of anemia and HHT, you know, the nosebleeds are really what we see as the very obvious bleeding. A lot of it comes from GI bleeding too, and a lot of people who have significant anemia, especially out of proportion to their nosebleeds, or wonder, my nosebleeds aren't that bad, why am I so anemic? That's somebody who needs to be evaluated for GI bleeding, because GI bleeding is pretty common. It's about 30% of older adults with HHT. So something to keep in mind when you're wondering about how much blood loss is really dangerous. When do I need to get things checked based on the amount of bleeding? Well, it's a little bit more complex than just the nosebleed piece.
Okay, great. Well, we have a couple of people have asked a variety of questions around Avastin, so maybe you can both sort of chime in here. But there are a lot of questions about, is Avastin good for preventing nosebleeds and therefore helping with anemia? And what different ways can it be administered, side effects, just a little bit of the whole gamut, if you wouldn't mind just touching base on that.
Sure. I'll start, and Dr. Al-Samkari can join in. So I think Avastin is something we all have started using more and more. The drug name is bevacizumab, and I say that because there are more than one brand name available now. There's something called Avastin. There's another one as well. So there are at least 3 different preparations of bevacizumab in the market. And there isn't any difference in how well they work. So you don't have to put your feet down and say, I will only take Avastin and not Avastin. That's happened to me a couple of times. And so it is effective. What you have to remember is it is only effective as long as you use it on an ongoing basis, like a lot of treatments. And so if you go out a few months from your last treatment, you will start noticing that the bleeding slowly starts to come back. And it is an anti-angiogenic medicine, so it inhibits one of the proteins that is involved in the creation of these abnormal blood vessels, of telangiectasias, that we develop with HHT. And so my practice is, and then I think a lot of the other HHT providers do the same thing, is to maintain people on Avastin on an ongoing basis for long periods of time. I've got people who are on the drug for many years now. We typically start the doses very close to each other, give it every 2 weeks for about 3 months or 6 doses, and then start spacing them out. And then that's when it starts to become personalized. I have some people who get a couple of doses every 3 months, others who get 1 dose every month. It's really depending on what works for each patient. As best we know, and this is to address some of the questions that have come up. As best we know, long-term use of this medication appears to be safe. In experience going out a few years, we have not seen any problems with it. Having said that, we don't have anybody who's getting a few doses a year going out 10, 15 years. So we're still learning, but so far it seems to be quite effective and quite safe. I'll let Dr. Al-Samkari chime in. He's got a lot of experience with this as well.
Yeah, absolutely. I mean, I think that was a really excellent summary. We could do a whole lecture on Avastin. We could do a whole Q&A on Avastin and related drugs. But that basically covers from A to Z kind of the basics. I would add to that, talk to your HHT specialist. If you are considering Avastin or other disease-modifying therapies in HHT, other anti-angiogenic therapies, and there are others that are right now also in clinical trials. If you're considering trying one of these drugs, it's just really important to talk about it with your HHT specialist. And just to point out, if the person who treats your HHT is not the person, does not prescribe these things or doesn't participate in the trials, then seek out someone who does, all right, and talk to that person about whether or not it would be a good option for you.
Great, thank you very much. So we have someone attending today who's saying that they're well past menopause and they find that their nosebleeds have reduced in volume and frequency, and they're just wondering if you've seen that in other HHT patients, or is that really unique to them?
Well, I mean, I think that's certainly very fortunate. I will say that in my experience, it's actually the opposite for most of my patients. Typically, for many of my female patients, their bleeding gets worse after menopause. Estrogen is it strengthens the blood vessel integrity and actually reduces bleeding. Estrogen, many years ago was used as a treatment for bleeding in HHT, and even today is still used as a treatment for severe hemorrhage in some patients, both men and women. And so when estrogen drops post-menopause, it's pretty common actually for bleeding to get worse, but it does, obviously the person asking the question, that wasn't the case, and that's very good. But it's not as typical in my experience.
So can I ask Kim to chime in? In your experience, has the bleeding gotten better or worse as you've gotten older?
Worse.
Worse. Okay.
Worse, yes, definitely. I had menopause early because after my son, I had terrible periods, and then I had an endometrial ablation. I had it in my early 40s, and I've bled. I mean, it's been terrible for, 15 years now.
Okay. So obviously a little bit unique maybe to that individual. I have several people asking if a person can't get to an HHT center, do the doctors at the centers, can they consult with local physicians? What would you recommend a patient do? So I'm going to ask both of you maybe to answer that based on your centers.
Sure. So I practice at UNC Chapel Hill. We're a small town, and so most of my patients come from outside of Chapel Hill, and we routinely collaborate with the local providers, whether for some people, it's a local primary care doctor. For some people, I actually have a local hematologist who's like a community hematologist oncologist who they will go to get their treatments, get their blood tests done. But then we will see them once a year. We will develop the treatment plan, and it's executed locally because that's a lot more convenient for the patient. And that's fairly routine practice for us. The local providers work well with us. They defer to us for the most part to make the big decisions in terms of treatment, but then they will execute the plan locally. And that setup has worked very well for my practice. What about you, man?
Yeah, so similar. I think what I would say to anybody who doesn't live near an HHT center, make the pilgrimage once. If you make the pilgrimage once and you are able to have the appointment, even if it's in a different state, able to have the appointment in person to meet the HHT center doctor. And if you have lots of problems with bleeding and anemia, then optimally hematologist that specializes in HHT if you can. But if not, just that, a HHT specialist at that center. It can really open the door to a lot of the collaboration with the local docs. I have a lot of patients that do this. My institution basically allows me, and especially now in the era of virtual visits happening very frequently, so long as there's been one visit that establishes care with that person, I'm able to follow that person virtually. At least those are the rules right now. That could change with time. But having that one visit literally lets me get to know my patient, and that way I can communicate with the local doc with a lot of knowledge about that person. And that's how I work with quite a lot of my patients that live not just in Massachusetts, but in other states as well.
And Kim, was that your experience?
Yeah, I was just going to chime in on that. Before Dr. Kasthuri was at UNC, I traveled to Augusta, Georgia to see Dr. Gossage. One time my whole family got tested and all those kind of things. And it made a huge difference because I was seeing a hematologist that was awesome in Raleigh, but he didn't know that much about HHT. And then once I went to see Dr. Gossage, they really communicated and came up with a really good treatment plan for me, with getting the iron infusions more regularly and more guidance about the ferritin levels and stuff like that made a big difference. But we did make the trek the one time, took the about 7-hour trip, because it's a lot of testing. At least there was like 3 days full of testing for different things, but it made me more knowledgeable, and the communication between my local hematologist and the center was phenomenal. And any question I ever had after that was phenomenal. Just they answered it quickly. And it was awesome. And then having Dr. Kasthuri only 3 hours away from me now is, I go to him, like I drive 3 hours to get to see him. To me, it's like nothing. It's like, okay, I can do that,
Well, and I would say from the Cure HHT Foundation perspective, I mean, that is what we encourage anyone who calls in looking for getting screening or care, or, we always tell them just go at least once. So you're a patient of record, then your local physicians can consult. And so I would tag on to that a question just about, because insurance is tricky. I know most of the centers will really try to work with a patient to try to get an appeal or approval for them to come. Would you agree?
Absolutely. We fight tooth and nail. I can't remember the last time we failed. So, but we really do, because there's only so many centers, and they have to get the argument that we make to the insurance company is that this is a specialized disease, a rare genetic disease, and they have to be seen at a center, and ours is the nearest for the patient, in order to get the optimal care.
Yeah. I echo that. We have a template that we have written. We have a letter to the insurance company that we have pre-formatted that we can fill in some of the blanks, but that speaks to this, saying, particularly if a person is from a state where there is no HHT center, then we can appeal and say this is a rare disease. It needs centers of excellence, and the patient does not have one in their state, and therefore they need to go out of state for care. Majority of the time, if not all the time, that's approved. But you do have to fight for it.
Great. Well, thank you for the fight. We do appreciate that, as I'm sure all the patients do as well. So kind of along those lines, we have a couple questions really kind of geared towards how does someone encourage their local hematologist to follow these guidelines? I guess if they don't have the ability to consult with a center, how do they convince their doctors that they need to do this?
Interview your doctor. If they're not listening to you, change doctors. I had a terrible hematologist one time that you know, her nurse told me she was trying to kill me because my hemoglobin was down in the 5 range, and she wouldn't give me a blood transfusion, and told me I did not hemorrhage blood. And you know, so you just, it's a team thing. If they're not listening to you, they're the expert, right? But you know your body better than anybody does. So you need to advocate for yourself. And if you're not getting what you need from one doctor, go talk to another doctor and see if you have a rapport with them. You can tell pretty much off the bat, like if you ask questions about your disease, and you know, ask if they're willing to work with one of the HHT specialists and things like that. You got to advocate for yourself.
Says it perfectly.
Yep. And I would say the guidelines that are now printed and available, and the reference cards that Cure HHT has made, are a great resource. I would sign up, I would print them off, and I would take them with you to your doctors and say, hey, look, you may not be aware of this, but there are all these guidelines now, and here's a copy for you, and could we start following the guidelines? I think most physicians, I won't say all of them, but most physicians are receptive to being given some sort of guidelines or documentation that they can follow when they're dealing with something that they don't have expertise in. And so I think that's the way to go about it, is to be your own advocate, like Kim said, and talk about the guidelines, share those documents with them, and then hopefully things will get better.
Okay, and we'll wrap up on this one, which is tied into that. We do have people from around the world on this webinar, and we have had a couple questions about, do you give consults with other countries? And in following the guidelines to with their doctors in their country. Now, I know we have international HHT centers. And I am going to post that link in our chat if anybody needs to go there, but I'll leave it to you all to respond to that as well.
The answer is yes. It's a more complex process. At least at Mass General, there's an international office that handles scheduling official international consultations. And I do those consultations, and many of my colleagues do as well. So it is possible. It takes a little bit more, I think, kind of bureaucracy to deal with. But yes, you can do it if there's not an HHT center in your country.
Yeah. So yeah, I'm happy to consult with people from out of the United States as well. My experiences are twofold. One, it depends on what it is we're trying to achieve. I've got a few families that I take care of out of this country, and I do it more on my time because I'm happy to pick up the phone or set up a Zoom call and talk to anybody. I don't do it as a formal consultation, write a report and bill for it. I just pick up the phone and talk to them and say, how can I help? And here's what you can do. That's got advantages and disadvantages. The advantage with that is it can happen quicker, but it is not meant to be any formal official communication. And therefore, there is no report that's going to be sent to a local provider who can then put it in their chart and officialize the whole thing. But it does give my patients some education and some guidance, like today's webinar, that they can then pursue further locally. So that's one thing that I have done and I continue to do. Or we can have a formal evaluation that would be a few more hoops to jump through, but can be done.
Well, thank you. And again, I just want to share our information for the foundation, that if you have any questions, need referrals, whatnot, you can get hold of us and we can connect you to the centers around the world. And so on behalf of everyone at Cure HHT, I just want to thank you for attending today's webinar and for staying connected with Cure HHT. Because we are here for you, and that's our patients, our providers, We're just constantly advocating for this disease and expanding treatment centers around the world. Cure HHT is grateful for today's speakers and for the McMahon family's commitment to, quote, pay it forward so that future generations have more effective treatments and ultimately a cure for HHT. Because without their financial support, the Guidelines Conference would not have been possible. And we also appreciate very much that several of the family members attended that conference to be a part of the landmark event. Remember that if you have not received your complimentary copy of our comprehensive guide to managing your HHT, let us know by completing the Join Us form on our website, curehht.org, and we'll be happy to send you or your providers one. In addition, after the webinar, you will receive a short survey, so please just take a few minutes to complete it so we can better serve you in the future. Again, I really want to thank Dr. Kasthuri, Dr. Al-Samkari, and Kim Nelson for volunteering their time today, especially on a weekend. And this program has been recorded and will ultimately be posted on our website. So we truly appreciate all of your participation, and we hope that you enjoy the rest of your weekend. Take care.
Thanks, everyone. Be safe.
Cool. Thanks, everyone.